Thank you very much for the opportunity to for me to be here today. You'll tell by my accent that I'm French Canadian, so bear with me if you have any questions or if you don't understand some terminology. So today I'll be talking about the effect of prenatal exposure to air pollution and childhood asthma. And I'm very glad that the two speakers that were before me sort of set the stage for what I'm going to be talking about here today. So we know that outdoor air pollution can have harmful effects in subgroups, in specific subgroup of the population. So, for example, in children, in pregnant women, the elderly, people who are in specific socioeconomic deprived status. We know that air pollution and pregnancy, there's a link. There's been many studies that have been done in the past decades. We know that there are physiological, anatomical changes that occur during pregnancy that may increase sort of the vulnerability of the pregnant women to the outdoor air pollutants. And many studies have looked at preterm birth, low birth weight, and many have found associations with some of the pollutants that were mentioned earlier today, like PM 2.5 and nitrogen dioxide, NO2. And some of the sort of pathophysiological mechanisms that have been sort of explored so far have involved a lot the sort of inflammation pathway, which is sort of the pathway where air pollution could affect inflammation markers, and these could be associated with sort of a trigger in triggering delivery. Sort of the increase in cytokine levels could be linked to the risk of premature birth. There's also the fact that air pollution could affect perhaps the nutrient transport to the placenta, and then it could affect also the risk of low birth weight. So these are just some of the mechanisms that have been explored so far. And for birth weight, in terms of birth weight as an outcome, so far the studies are sort of pointing out that early periods of pregnancies are probably the most vulnerable for the risk of low birth weight. And the results so far for the timing of exposure for premature birth is a little bit more mixed. So there are still ongoing studies on this issue. And now that sort of brings me to the topic about the air pollution and the linkage with lung function in children, because there's been quite a number of studies looking at this important issue. And the link between air pollution and lung function in children has mainly been investigated when studies have looked at, for example, early life exposures to air pollution. Few studies have looked also at in utero exposure to air pollution. And then subsequently later, they evaluated lung function. So they looked at, for example, a forced expiratory volume in 1 second, FEV1 or FVC as the main outcomes. And they found some of these studies found associations. So meaning that air pollution would affect lung function in children. And this here is sort of an example of a study that was published over 10 years ago that sort of showed that as the levels on the x-axis, as the levels of NO2, nitrogen dioxide, which is a marker of traffic pollution, as the levels were increasing, the FEV1, sort of a measure for lung function here, was decreasing. So increasing levels of NO2, decreasing levels of FEV1 in this case. And the effect that have been investigated and the effect that have been found so far have mainly been on FEV1. as a measure of lung function. So for the studies that have looked at this issue, the reduction in lung function is reported in association with traffic pollution with deficits of about a few percent. So for every increase in levels of air pollution, we see deficits of a few percent in lung function. So this may sound like it's minimal on an individual point of view, but when you think about it, it's a small shift in the population distribution of lung function may increase the prevalence of those that will have lung function deficits in the long term. And as we learned in our previous presentation, these can have long-term implications for the children and even going into adulthood. And so most of the studies that have been done on the link between air pollution and lung function have been cross-sectional. So cross-sectional studies are the ones that are being done at one point in time. So we measure, for example, air pollution, and then we would measure lung function within sort of the same time frame. So the timing of exposure has been sort of unexplored. There's been one study conducted by Morales and collaborators and published in 2015, and this study was done in Spain. They identified that the second trimester was probably the most vulnerable trimester for the exposure to NO2 on lung function deficits that were measured during childhood years. So this brings me to the interest of looking at prenatal exposure on childhood asthma. So there's been a number of studies looking at lung function measures, but there's sort of a shift looking at childhood asthma as an outcome. And there is suggestive evidence that air pollution will affect childhood asthma in the long term. As we've learned in our previous presentation today. And now the question is about what's the timing of exposure? What's the most vulnerable period for the exposure to air pollution to be associated with the development of childhood asthma? And so there are a few studies that have actually looked at specific periods of vulnerability. There's also the fact that it's hard to sort of disentangle the effect in early childhood versus the effect in utero. So it's been quite difficult in studies so far for many reasons, methodological issues, exposure assessment issues with the measurements of air pollution that were used. And the other thing is that there's an interest in the scientific literature to understand better the effect modifiers. So we know that there's a possible link between the exposure to air pollution in utero on childhood asthma development, but then are they specific vulnerable groups of women during pregnancy that may be at an enhanced effect or at a higher risk of being exposed to air pollution on the risk of having a child with asthma. So maternal asthma is a major risk factor, as you probably know, for the development of childhood asthma. And one interest is about knowing if the sort of combination of those that have asthma and the fact that they're exposed to higher levels of air pollution, are these two factors combined together acting synergistically in the incidence of childhood asthma? So that's sort of a research question that myself, my colleagues were interested in. So this is just a systematic review that was published this year, a very good systematic review that sort of evaluated the link between air pollution and childhood asthma. And it goes from in utero childhood exposures and what are the future research directions that should be aimed. I was not involved in the study. It was just a good paper that I thought I might share with you. So what I'm going to do now for the next few minutes, I'm going to show you the study that we did in the province of Ontario in Canada where we looked at the issue of in utero exposure to air pollution on childhood asthma incidence and trying to disentangle the effect with the in utero versus the early life period. So the findings that I'm presenting to you are being considered in a journal right now. So these are fresh findings, unpublished, but may be published eventually, hopefully in the next year. So the research objectives of this study were to first evaluate the associations between exposures to air pollution during pregnancy, so specifically PM 2.5 as sort of an indicator of the mixture of air pollution, and NO2, which is a marker of traffic pollution. And we wanted to also look at whether these associations were modified by specific effect modifiers. And for today's presentation, I'm going to focus on maternal asthma as a possible effect modifier. So we did this study in the province of Ontario. We used health administrative data. So because of the universal health coverage, we have access to a bunch of rich data, and we're able to link data sets together. So we went and had access to a data set called BORN, B-O-R-N, so it's Better Outcomes Registry Network, which goes from 2006, and for this study, we stopped the follow-up in 2012. So 2006 to 2012, we used this birth registry where we have information on children across the province that were born, whether it was in hospitals or in midwives' settings. And then we linked the data with other data sets so that we could identify children and mothers who have asthma. So the outcome in this study was childhood asthma diagnosed before 6 years of age. So we were sort of focusing on preschool age because we were mainly looking at the in utero period and the early life period. And the exposures were PM 2.5. So we used satellite data. We have a surface of measurements of PM 2.5 across the country. So we used the surface for the province of Ontario, where we have basically measurements of PM 2.5 at a 1 by 1 kilometer resolution. So for every postal codes across the province, we were able to assign the exposure during the pregnancy period. And because we had information on the mother, where she lived during pregnancy and whether she moved, so we were able to capture residential mobility as well. And we had also information on nitrogen dioxide. So nitrogen dioxide was sort of a marker for traffic-related air pollution. So both of these air pollution measurements were available on a fine temporal resolution so that we could assign the exposure during the different trimesters of a pregnancy. So this is just sort of an idea of what a surface would look like for satellite measurements of PM 2.5. We have basically measurements for the whole country. There's also measurements available for the US. And the measurements for PM 2.5 are sort of a combination of satellite and some of my colleagues who work in the Department of Physics at Dalhousie University in Halifax, they came out with this sort of measurements where they combine monitors, simulation models, plus the satellite measurements so that we can have a very accurate measure of PM 2.5. And this is just a slide showing you the linkages that we did with the different health administrative data. So our baseline data was basically the Better Outcomes Registry Network, which is the birth registry. We linked this birth registry with another database that we have in Ontario. It's called the Ontario Asthma Surveillance Information System. So it basically covers everyone who has been diagnosed with asthma And we have an algorithm that has been validated with medical records where we have a high sensitivity, high specificity, and it's physician-diagnosed asthma. So we are able to capture those children that after birth were diagnosed with asthma, and then we were also able to capture mothers that had asthma during pregnancy. And we also linked with census data so that we could capture some socioeconomic status variables. We previously published another paper just to show you that this sort of approach, these same databases have been previously used, where we looked at air pollution, but in this case, childhood cancers. I think earlier, some of the presenters talked about the issue that air pollution can affect cancer in the long term. And the issue here was, is air pollution associated with childhood cancers? We're seeing these increased incidence of childhood cancers in industrialized countries. So are any environmental factors involved in the equation? And this is a study that was published earlier this year, actually. And we found that PM2.5 was associated with the risk of astrocytoma, which is a very specific type of brain tumor in children, and especially the first trimester exposure was associated with that. NO2, nitrogen dioxide, was associated with leukemia, which was as expected. Previous studies have shown this link before. And we've looked also at birth outcomes as outcomes as well in another paper. So our covariates that were used were, we had many covariates. We had obviously the birth date, the weight of the infant at birth, the infant's sex, gestational age, the maternal age at delivery, whether the mother smoked during pregnancy, parity, the intention to breastfeed, so the maternal asthma status. We had some information on residential greenness. So that's another sort of important environmental factor that we see more and more in the scientific literature, whether green measures, green space is associated with reductions in incidence of asthma in children. So we adjusted for greenness, and we also had information on socioeconomic status variables. So we did statistical analysis. This is a cohort study analysis, so we used a Cox proportional hazard model, which is pretty standard in this type of analysis since it's a time to event analysis. And we looked at the effect modification with maternal asthma. And so I'm gonna just show you some descriptive statistics and then gonna go through some selected results. We have a lot of results based on this study, but I'm just going to focus on probably the main findings. We had a population of 760,000 mother-infant pairs. We only looked at singleton birth, and we had about 110,000 or 111,000 children with asthma, about 45,000 women that had asthma. And the average time from birth until the asthma diagnosis was about 2 years of age. Nitrogen dioxide and both PM2.5, the results that I'm going to show you are presented as risks per increments of interquartile range. So this is pretty standard in the environmental epidemiology field, where every increase in risk is with the interquartile range. So the interquartile range is really using the 75th percentile minus the 25th percentile. And in this case, for NO2, the IQR was 9.6 particles per billion, and PM2.5, it was 4.1 micrograms per cubic meter. And so this is our sort of main finding. We stratified results by trimesters, and we also look at the overall pregnancy exposure. On your left, there's findings for the NO2, and then on the right, the PM2.5. So what we are seeing basically is that it seems that NO2 in the early periods of pregnancy, the first and second trimesters, it seems to be the most vulnerable periods, And then the overall pregnancy exposure appears to be at an increased risk, but it's probably driven by the first and second trimesters. And then for PM2.5, results are mainly focused on the second trimester exposure. So that's sort of interesting because it's sort of consistent with the prior literature, the few studies that have been done so far. And then what we wanted to do is disentangle the effect of prenatal versus early life exposures. And so in our models, in our statistical models, when we investigated every trimesters and the pregnancy exposure, we adjusted for the first year of life in order to really sort of disentangle the effect. And then in this case, the sort of risk, as you can tell, are dropping compared to the previous slide I just showed you. But for NO2, as well as PM2.5, the effects are focused on the second trimester exposure. And then we also looked at the effect modification by maternal asthma. We used an approach where we investigate the synergistic effect. So in the epidemiological field, this is using something called the relative excess risk due to interaction. This is pretty common when looking at synergistic effects. And in this case, this table is looking at PM2.5. We created a new variable. This new variable is sort of the combination of whether the woman has asthma or not, and the levels of the specific pollutant by quartiles. So the first level would be maternal asthma, no, and PM2.5 in quartile number 1. So that's our reference category, the baseline category. And then we compare all other categories to this baseline category. And the last line in this table is maternal asthma, yes, and exposed to the high level of PM2.5, which is quartile number 4. So in this case, this effect modification table, according to the p-value we obtain, which is shown at the bottom of the table, is not statistically significant for PM2.5. So it's not indicating that there's a synergistic effect between PM2.5 and the maternal asthma status. However, when we look at NO2, we have a statistically significant effect. Actually, this p-value is 0.04. It shouldn't be 0.40. I'm sorry. So the results are statistically significant in this case. So when we combine maternal asthma and the highest quartile of NO2, we have a risk of 1.77. So the combination of both factors sort of create a synergy in the asthma incidence in the children. And so we also looked at concentration response curve in the clinical setting. It would be compared to dose response curve because we really want to know if the effects are only being seen at low levels. Is there a threshold? So in this case, it seems that because the levels are starting at about 8 or 9 particles per billion, it seems that the effect is sort of linear in the case of NO2 on the risk of childhood asthma. So on the x-axis, it's the NO2 concentration, and on the y-axis, it's the risk of asthma in the children that's increasing. So that's a graph specifically for the second trimester of exposure to NO2. And then we sort of saw the similar effect for PM2.5 for the second trimester effect, sort of a linear relationship, almost linear relationship. So the lowest levels that were observed were around 2.5 micrograms per cubic meter. So in our study, just to summarize the findings, is that we observed some significant findings with the exposure to NO2 and PM2.5 on childhood asthma incidence, and it seems that the second trimester is the most vulnerable trimester of exposure. And so it it is consistent with the only 3 previous studies that have been done. The study by Morales that was published in 2015 that looked at lung function. They saw an association with NO2 in the second trimester. And a very good study that was conducted in Boston. You may be familiar, for those that are in the environmental epidemiology field, Joel Schwartz, who's got a very good team of researchers there. One of his students published this study in the American Journal of Respiratory Critical Care Medicine a few years ago. And so they observe an association with PM 2.5 in the second trimester. And then a study conducted in China also saw this association with the second trimester for NO2 on childhood asthma. And then where we go sort of one step further is that we have sort of suggestive evidence that children of mothers who have a history of asthma and who were in the upper quartile of exposure to NO2 during the prenatal period were 1.7 times more at risk of developing asthma when compared to children of mothers who don't have asthma and who are in the first 25th percentile. So there are many sort of mechanisms that may be involved here. We know that air pollution is associated with systemic inflammation, oxidative stress. So there are probably different pathways that are involved in the findings that we observed. For the effect modification with maternal asthma, it's sort of a new finding, and it's still difficult to explain. Perhaps one explanation may be the fact that the exposure to air pollution during pregnancy may lead to some level of exacerbation of maternal asthma, which the two together may sort of enhance susceptibility, enhance the level of inflammation, which could be associated with the incidence of childhood asthma. And so on a regulatory point of view, these findings are important because it is adding to the weight of evidence that reductions in air pollution will be beneficial in reducing health outcomes, in this case in children. And so even at low-level concentrations, like what we've observed in Canada, we still see effects. So this is important for the regulatory point of view. On the clinical side of things, these findings suggest that maternal asthma may modify this relationship. And so clear advices should be given to pregnant women who may be exposed to outdoor air pollution. And so we use, at a national level in Canada, the Air Quality Health Index, which earlier the Air Quality Index was mentioned. And so it's sort of a similar approach where we can instruct patients and pregnant women about how to verify maybe outdoor air pollution on an application on a cell phone, and perhaps reorganize their activities during a day, because maybe there's a smog alert, maybe the PM levels are expected to be high. So we know that in our case, we have a number of vulnerable groups that have been identified in the sort of messaging of Air Quality Health Index, and those that are pregnant, patients with that are pregnant are considered in the vulnerable groups. So there are also other vulnerable groups. Children, people who have specific comorbidities are also in there. Perhaps people who work outdoors. And so this is sort of similar that from what was mentioned earlier, where there's a level that can go from 1 to above 10, and then it's graded according to the level of risk. And then there are specific messages, health messages that are given. And then it's important for clinicians to understand this so that it can get translated to patients, so that they can understand how to manage their daily activities based on the different levels of AQHI. There's a number of limitations in our study that we conducted. There's a lack of information in our study on maternal obesity in pregnancy. Maternal obesity is a risk factor for the development of childhood asthma. And maternal gestational weight gain, we didn't have information on maternal stress. However, we still adjusted for socioeconomic status, so it may capture some of the maternal stress confounding. And we also did not have information on specific asthma phenotypes and the severity of asthma in pregnant women. So this is sort of limitations in our study. But some of our strengths is definitely the large sample size, probably one of the largest study done to date on this issue. The availability of air pollution across a wide geographical area, and the fact that we adjusted quite for a good number of confounding factors. So the next step for us, for myself, for my colleagues, it's really to better understand the sort of mechanism that's involved. We're involved in measuring oxidative potential of particulate matter, which is sort of perhaps a new way forward in understanding the mechanism. We're also interested in looking at ultrafine particles, the very, very fine particles, on whether these ultrafine particles are sort of driving the risk of childhood asthma. So this study will be done specifically in Toronto. And some recommendations for future studies. We recommend that we should keep on refining the time periods of exposure so that we can better capture the different time periods of vulnerability. And also perhaps what was mentioned earlier, and I know there's a presentation coming on pollen, aeroallergen, the interactions between air pollution and aeroallergens. This is sort of a very important aspect to investigate. And we plan on actually doing some measurements of aeroallergen in the city of Toronto in Canada to better understand the sort of spatial distribution and the interactions with air pollution. So I'm grateful to my colleagues that have been very, very helpful in bringing this study forward. And whenever question period will become, I'll be able to answer questions. Thank you.